So good evening, everyone, and welcome to webinar number 80 of iBreastBook. It's great to see that we're still getting numbers and still getting people from all across the world. It's great to see we have an excellent panel with us. Usually we try October time to make the webinar slightly a bit less technical, a bit less about treatments. It's more about survivorship and other issues in relation to breast cancer treatments. So we have two themes today. We have a theme about side effects of treatments, especially chemotherapy and endocrine treatment, as we're treating now breast cancer as a chronic disease. Ladies are living long, and we just need to know how to deal with that. And the other part of that will be talking about lifestyle measures and breast cancer, and about things like exercise, things like diet, things like weight, and we'll see how they affect survivorship, as those are very important things. We have great speakers from all across the world. We have Marion Schmidt from the Netherlands. We have Sani also from the Netherlands. We have Emma Sparrow and Farhat Raja from the UK. We have Jay Harness from the USA. Come to Jay Harness from the States, and Jay is one of the senior surgeons from the States in Arizona, currently working, if I'm not mistaken, and he's going to talk about exercise. And he runs a lovely group about exercise and breast cancer, and he keeps everybody informed. So it's great to hear from him, from Jay, about this. Jay, the next 15 minutes are all yours.
Well, thank you very much. I'm sitting here with a big smile on my face because these three prior talks are the perfect segue to what I would like to talk about, which is exercise oncology, which is a term that most folks in the medical world haven't even heard before, let alone know that much about. I also want to acknowledge two other people who have contributed slides to this presentation. The first is Catherine, known as Katie Schmitz, who's a professor of hematology oncology, University of Pittsburgh Medical Center, past president of the American College of Sports Medicine, and the founder of Moving Through Cancer. And also Dr. Karen Wonders, who is a professor of exercise physiology at Wright State University and the founder of Maple Tree Cancer Alliance. Why is my slide now? There we go. Let's do it this way. If you remember no other slide from my talk today, please remember this one. This is sort of the history of the evolution of exercise oncology. Starting back in 1990 were some of the original randomized controlled clinical trials. Up through this year, we've now got over 3,000 of them, resulting in 30,000 publications. I have said to people, if we had this much science about a new surgical procedure, it certainly would have been standard of care a long time ago. And then when I say, why are we in oncology not familiar with all of this data and all these publications? The answer is really very straightforward. It's because these clinical trials were predominantly done by PhD, outstanding researchers in exercise physiology, kinesiology, and even sports medicine, and primarily published in their literature. So until the last few years, there's been very little crossover into our oncology literature. When I bring up the term exercise oncology, people say, well, what is that? And I think one of the ways of thinking of it is an adjunctive therapeutic approach to cancer patients that have emerged from these over 3,000 prospective clinical trials conducted over the last 35 years. And as we've already been talking about, when we talk about the side effects of chemotherapy, hormonal therapy, and lifestyle issues, these clinical trials have resulted in moderate to strong evidence of the positive impact of exercise on the patient's fatigue, their anxiety, their depression, their quality of life, physical function, sleep, bone health, and breast cancer-related lymphedema, not only in the prevention of lymphedema, but also in the treatment of lymphedema. It's important to remember that exercise oncology programs are evidence-based programs of, and here's the key words here, supervised, individualized exercise training done on site or virtually. And our goal is to try and make exercise oncology programs an international standard of adjunctive care as it already is in Australia, who are some of the real important world leaders. And I think it's also important for us to think about exercise as medicine, which has come from the American College of Sports Medicine. Now, Maple Tree Cancer Alliance in Ohio, that I'm affiliated with, has a prospective database. And here's some data from 11,248 patients on the physical and psychological impact of exercise programs during active treatment. Nearly a 60% increase in quality of life, increased cardiovascular endurance, muscular endurance, flexibility. And here's really important, nearly a 76% increase in feeling more positive and nearly a 60% increase in feelings of support. People then bring up all the time, is there a financial impact of these kinds of organized programs? And again, from the Maple Tree database, they have found a decrease in hospital inpatient stay by about 6%, decrease in length of hospital stays by nearly 20%, a big decrease in emergency room visits by nearly 30%, decrease in overall total patient encounters by a third, 33%, and a decrease in readmissions approaching 50%. If you look at all this data, and I should have pointed out on my first big slide, 65% of the clinical trials that have been conducted over the last 35 years have actually involved breast cancer patients. And if we amalgamate all the data from these studies, what we see is about a 31% reduced risk of cancer-specific mortality, a 22% reduced recurrence rate. And here's the biggest impact of all, whether it's in breast cancer or other cancers, a reduction in all-cause mortality of around 41%, and particularly in cardiovascular disease. If we talk about what's the prescription for exercise during active treatment and into long-term survivorship, the national and international standard is 150 minutes a week. And I really want to emphasize this. We're talking about moderate intensity exercise. As a good example, 5 days a week of walking briskly for about 30 minutes and 2, maybe 3 times a week of resistance training. Many people have thought, Jay Harness, you're advocating for the Ironman competition or training for marathons. No, I'm not. I'm advocating for some moderate intensity activity. Here in the US, the National Accreditation Program for Breast Center Standards were revised and released last year, and now the standards ask centers to document policies for exercise recommendations. The ASCO guidelines that came out a few years ago, this is important to read these. Oncology providers should recommend regular aerobic and resistance exercise during active treatment with curative intent to mitigate the side effects of cancer treatment. This means with curative intent stages 1 through 3, but even more data is coming about the benefits of patients with stage 4 disease. If you look at the NCCN survivorship guidelines, they're virtually identical to these. So we've got big name groups, including ASCO, NCCN, American Cancer Society, the National Cancer Institute, and others here in the US that are strongly advocating for these standards. In the NAPBC standards, what we're talking about are programming, referring for exercise programming, including part of the pre-surgical assessment, has been already pointed out in prehab, getting patients ready for neoadjuvant chemotherapy for triple negative or HER2 new positive breast cancers. There's a lead time here of a few weeks. Let's get our patients moving. Post-surgical referrals, particularly during chemotherapy. A lot of the clinical trials that have come out about chemotherapy have clearly demonstrated better compliance with dose-dense recommendations, better tolerance of chemotherapy, et cetera, and particularly in the long-term survivorship. Let me just highlight in the next couple of minutes some recent publications. Here's one from this year: Exercise and Survival Benefits in Cancer Patients, Evidence from a Comprehensive Meta-Analysis. This was 151 cohorts of 1.5 million cancer patients across breast, lung, prostate, colorectal, and skin cancer. Again, similar to the numbers I've shown you. In this study, the lower risk of death in cancer patients ranges from 31 to 36%. For prostate cancer patients, 27 to 37% reduction in mortality. Lung cancer, 22 to 24% reduction. Colorectal, and I'll talk about the challenge trial in a moment, a 29% lower all-cause and cancer-specific mortality. I have said to my colleagues repeatedly, if we had this much scientific data for a new surgical procedure of breast cancer, it would have been the standard of care 10 years or more ago. What about cost savings? One of the big barriers in the United States is not having reimbursement yet. Here's a lovely study done by Karen Wonders, Katie Schmitz, and others at Maple Tree that involved 243 women with early stage 1 and 2 breast cancers, randomized prospectively to an exercise group of 123 people and a control group of 120 patients. It involved 12 weeks, again, of supervised, individualized exercise programs, aerobic, resistance, flexibility, following the American College of Sports Medicine guidelines. The exercise group showed significant improvements, and I've highlighted some of these already. Here's another study: cardiovascular fitness by nearly 10%, muscular endurance around 14%, strength 3%, flexibility, but with no improvements in any of these in the control group. The major cost savings were from fewer emergency room visits, unplanned hospitalizations, and decreased office visits. They actually try to quantify this in the control groups. It was nearly $8,600 per patient in costs, where cost savings in the exercise group are around $6,300. If there's ever been a really huge clinical trial in the world of structured exercise after adjuvant therapy, this is the Challenge clinical trial that was just presented on June 1st at ASCO. In fact, I was watching it on live streaming with an audience, gave them a standing ovation after Carrie's group presented this study. This took, folks, 20 years to conduct, from inception to finally being presented at ASCO. It involved 55 sites, predominantly in Canada and Australia, as well as some other sites. 889 patients were prospectively randomized, about 442 to the exercise intervention, 447 to the health education group. The participants in the study had completed their surgery and their adjuvant chemotherapy for high-risk stage 2 or stage 3 colon cancers. The structured exercise group consisted of 3 years of behavioral support intervention designed to achieve 10 med hours per week of recreational aerobic exercise. This is the equivalent to brisk walking 3 to 4 times a week for about 45 to 60 minutes. The health education group received standard survivorship health education materials, but no structured exercise programming. The median follow-up here was nearly 8 years. The exercise group had a 28% reduction in recurrence of their original disease, a new cancer, or death. And the exercise group had an overall survival benefit by 37%. When this was presented and then simultaneously published in the New England Journal of Medicine the same day, it got a standing ovation at ASCO. And accompanying that presentation in the New England Journal was this editorial that talks about extending cancer survival with exercise, a time for oncology to act. And I couldn't agree more. And I would recommend this editorial and the study for everybody, excuse me. So here's the big question. We've got 35 years worth of improved clinical outcomes with exercise oncology program. I think the $64 question is, what's happening at the physiologically to give these results? And the focus right now is on two areas, the immune system and muscles. And this cartoon nicely demonstrates the anti-cancer elements released by the immune system with exercise, natural killer cells, cytotoxic T cells, macrophages, and something that most of us are not familiar with, which are myokines. Myokines are small protein particles that are both cytokines and peptides secreted by the contracting skeletal muscle during physical activity. They have a direct anti-tumoral effect, anti-inflammatory actions, immune system activation, and inhibitions of angiogenesis. Here's a paper that came out a year ago that really summarizes. I won't bore you with all of these factors that are released here, but as you can see, there are a boatload of things released. Now, when we talk about immunotherapy, as has already been pointed out, I think immunotherapy is a double-edged sword. We've seen really phenomenal results in lung cancer and malignant melanoma, where immunotherapy is a standard of care for these certain types. But can these therapies become more active during neoadjuvant exercise programs such as prehab? And as has already been pointed out, are we really talking about a double-edged sword here? And I think we should talk about this during our upcoming discussions, because I'd like to think of the enhancement of the immune system as an adjunct to helping immunotherapies work better. And there have been reports in the literature in prehab or neoadjuvant exercise on neoadjuvant chemotherapy regimens, where in some of the reports there's actually been increased complete pathologic response rates. But anyway, this is a nice summary of what's going on with exercise. Exercise oncology programs there can be shown to have a proven effect on common symptoms of active treatment, can improve chemotherapy completion rates, are cost effective. Exercise oncology programs we need to really think of as a continuum of care from rehabilitation during active treatment and into long-term survivorship. And I'd like to hope that not only in Australia, but coming soon, this will become a standard of care everywhere. A recent publication that I would absolutely recommend that everybody take a look at from the Journal of the National Cancer Institute is a recently received monograph on the update on exercise oncology, and think of it as a multidisciplinary perspective around the globe, particularly Katie Schmidt's opening commentary here that has really come of age, and all of these other fabulous publications we've got in this journal. As I wrap up, let me tell everybody about the creation about a year or so ago of the International Society of Exercise Oncology, ISEO. This society is global. It's a society that is newly organized to increase awareness of the critical role that exercise plays in cancer prevention, as we just talked about with obesity, in the treatment, in the survivorship. The highest priority is changing this to make it a standard of care throughout the world. Our first inaugural meeting will actually be in Heidelberg, Germany next July, and the website is exercise-oncology.org. And then my final slide is about the website that I started about 10 months ago called Cancer Fitness. The website can be found at cancerfitness.org. This is all about the description of what the heck exercise oncology is, Plus, we have videos, written blogs, and other things. And finally, at the site, I've got an email list of almost 450 people in 24 countries. If any of you would like to be added to that email list, there's a link at the website to be added, or you can email me. This is my email address below, jkharness@gmail.com. Thank you for the privilege of your time.
Fantastic talk, Jay, and thank you for being part of this. Now, let's start discussing that. I still remember 2 years ago or last year, we had Liz Oridian on this webinar, and she talked about exercise, and she had fantastic talk about lifestyle measures, mainly from own experience. And there's lots of things to be said about diet, about weight, about smoking, about exercise. But let's start with Emma and Farad. Of course, I'll put you on the spot. Is there any comments or any questions you have for the speakers?
Yes, thank you, Jay. I think that was a fantastic summary, and it is a subject which is really close to my heart because I think that we are not good at allowing patients to do things for themselves. We kind of very good at giving prescriptions of medications and treatments and telling them about all of our clinical trials that will allow them to be recurrence free, or if they are secondary breast cancer, how they could live longer. But we just seem to fail at empowering patients and really giving them the tools to improve their own outcomes. And I think exercise oncology has got to be one of the biggest things that we push in the next decade or so. I think every hospital, every oncology department, every cancer hospital should have an exercise oncology area. Whether that's exercise on site, whether that's somewhere where you can get information, whether that's somewhere where you can actually have resource. I don't know, but there has to be some protocols because it's clear. I don't think there's a person on this planet who doesn't know that exercise is good for you, but there's a whole load of people who don't do it. So why are they not doing it? So I think there needs to be the next step where we actually make people feel like they want to exercise rather than make them feel guilty about the fact that they're not exercising.
That makes
Oh,
sense.
those are outstanding comments. Thank you very much. What's really key here is for all of us, med-oncs, rad-oncs, surg-oncs, to make a referral, to make a strong recommendation to our patients to do it. Simply handing them a brochure doesn't work. We know the brochure therapy does not work. And so referring to programs out in the community, referring to medical center based programs are really key. We're dealing with the barrier in the United States of the lack of reimbursement. The group I'm with, Maple Trees, in over 80 locations in the US, often it's been the hospital foundations that will fund the programs or other philanthropic sources that will fund programs at the medical center levels. You've got groups like the YMCA that offer the Live Strong programs, but that initial push needs to come from us to our patients, okay?
Emma, you wanted to mention something?
Yeah, I just wanted to sort of talk a little bit or comment really a little bit about the management of lifestyle factors in patients, exercise, weight control, alcohol, smoking, sometimes recreational drugs. But actually, a lot of this, and I don't know that we've mentioned it, pertains to the level of deprivation that you work in. And certainly myself and Farah work in communities that have quite a high deprivation index. And actually, it's very difficult, I think, to engage a lot of people who have a lot of social problems and actually can't necessarily access the right educational support or even just the basics to help them manage their lifestyle modifications. And actually, I think that's a major piece that needs addressing as well.
And I agree with that. And I want Marilyn to speak a bit about the study she's designing. It's not only about during treatment, it's also about survivorship and later. So Marilyn, the protocol that you sent for Da Vinci is fantastic. Do you want to mention that?
Yeah, we designed a Vinci study, and it's a study which is if we get the Horizon Money Grant, obviously, is including patients after standard breast cancer care and is randomizing patients to a combined lifestyle intervention for over 2 years. And it has to be a long period, like 2 years, to make sure that the whole change is sustainable. And the whole intervention is paid for by the grant organization or by the Dutch government. And I think that's a really important thing, because it doesn't make any sense if people don't have the money to buy running shoes to send them to running. And that's a really, really big problem. And that's why it's really nice that in Holland, we have a guideline now on breast cancer and lifestyle, and it's connecting the Dutch breast cancer guideline to the guideline on overweight and obesity, but it's also referring to exercise programs. And we have like a web all over the Netherlands, including all these hubs to sporting, to lifestyle coaching, anything. So that's we're really gracious for that, because that is really important.
Perfect. Terry, you want to say something?
Yes. Marjolaine, I like your backdrop and your bike. Good job. What I would like to say, as a cancer patient who has been through chemotherapy, surgery, radiation, all the things, what exercise does, and what Dr. Harness talked about, is it helps breast cancer patients regain confidence in a body that they sometimes think betrayed them. So that's what exercise oncology does. And to your points, Marjolaine, and saying about, what if patients can't afford a pair of shoes to go walking? Or what if they're in an environment where they don't feel safe to even get outside and walk because of their neighborhood? It does not cost anything to turn on some music, which is uplifting, and dance right in your space, no matter how big or how small it is. Movement is key. And if I can put in a shameless plug, because I am a total Dr. Harness girl fan, we have a video coming up. He talked about the cancerfitness.org website, and Dr. Harness goes through the entire website. Stay tuned. It will be published on the Deep Sea Foundation YouTube channel. That's my shameless plug for this morning. To all of you, thank you for this topic. It is so important in the breast cancer community and in the cancer community at large. So thank you very much.
I think we're nearly coming to the close. It's nearly 6 o'clock here in the UK. I know it's only still 10 o'clock in the morning for you, Terry and Jay, maybe, but here it's nearly 6 o'clock in the evening. So, any final comments from anybody?
Thank you for
Perfect.
the privilege of being here. It's really been
Yeah.
fantastic. Thank you very much.
Thank
Yeah,
you for
thank you.
giving up your time. And anybody that wants to watch this webinar, it is already live on the YouTube channel. Few people have started watching it there. So it's all for free. So if anybody wants to watch, I'll start sharing on the social media. Now, thank you for giving up your time to be with us today, and giving up 2 hours on a Saturday, which is a